Good morning. I've been asked to talk about modulating the cornea in patients who are off target with refractive IOLs. This is more of a block and tackle type talk for you. I do have a financial relationship with B&L and Clario, but these are not relevant to my discussion. So, you've heard about a whole variety of multifocal IOLs in Paris at ESCRS. The trifocals are really taking a big lead in terms of market share in Europe. And more recently, we've had one trifocal IOL approved by the FDA in the United States. With all these lenses, as you've heard by other speakers, but I'm going to convince you even more, it's absolutely critical to correct out residual refractive error. So when I look at these patients, I look at whether these patients are 20 happy or 20 unhappy. If they're 20 happy, they see well at distance, intermediate, and near. My first rule of thumb is if it's not broke, don't fix it. If they're 20 unhappy, then I go ahead and look at their residual refractive error. I try to find that. My technicians are sort of black belt refractionists. And if we find it, then we'll go out and try to correct that out. Now, if they don't have residual refractive error, then we'll go and look for the usual suspects. And those usual suspects are basically retinal, PCO, irregular astigmatism. It can be caused by ABMD or dry eye or other causes, unrealistic expectations. But the one that we can really do the most good for is refractive error. That's the one that we can get the biggest bang for our buck in terms of correcting out. So Dick Lindstrom years ago basically said that at 1 to 3 months, over 57% of eyes may not have the full visual benefit of correcting with a refractive multifocal IOL because of refractive error. And the multifocal lenses, as I'll show you, are disproportionately affected by refractive error. In 2 studies, anywhere from over 10 to 25% of eyes needed a secondary procedure to correct out that residual refractive error, either a lens exchange or more commonly either LASIK or PRK. And this is really an important point. If you're going to be doing multifocals, premium IOLs, you really want to have the option of correcting out that residual refractive error, be it you doing PRK or learning PRK or having a surgeon that you can rely on that can help you with that. So understanding the optics is absolutely critical in this, and you heard this over several talks today, but I can't overemphasize this. Looking at the ocular surface, the corneal topography, looking for anterior basement membrane dystrophy. This patient was unhappy, referred in after a multifocal, had contact lens-induced corneal distortion. This patient probably shouldn't have had a multifocal in the first place. We were able to correct out some of this with astigmatism, but these are more challenging to correct and best avoided with multifocals. When we evaluate these patients, we do manifest refraction, try to pick up any kind of refractive error, and my technicians literally compete to pick out 3/4 of a diopter of hyperopia or 3/4 of a diopter of astigmatism. If we find it, then we put it into a trial lens frame and let the patient walk around the clinic. We let them walk outside, we bring them back in, we put a near card up, we ask them, does this help? We show them, we lift it up and down, and if it does, then we know we're onto the right thing and we can correct that refractive error out. If it's questionable, we may put it into a soft contact lens, let them use that for a few weeks, or even into their old spectacle correction. If we find that, then we know we're on to being able to correct it. Now, multifocals, diffractive IOLs, EDOFs, are very sensitive to refractive error. Even 3/4 of a diopter of astigmatism can be visually significant and can reduce image quality. But this in combination with irregular astigmatism, subtle PCO, a large angle kappa, dry eye, ABMD, these all are additive. So it's not just the astigmatism, but it's all these things combined that reduce image quality in these patients, and we need to be very aware of that. This is a study that we did in our University of Rochester optics metrology lab, where we took a group of multifocals, compared it to a monofocal, and basically what we did is corrected out the refractive error and then added increasing amounts of astigmatism. In the light orange and the darker orange, 3/4 of a diopter of astigmatism and 1 diopter of astigmatism clearly dramatically reduce image quality compared to a monofocal. So you really want to go chase this amount of astigmatism in these patients if they're symptomatic. So how do we approach this? Well, I use LASIK for healthy eyes, even in older patients. It gives them quick visual recovery. And we measure multiple times, actually, that refractive error to make sure it's congruent, and then we'll go ahead and treat it. We can also use PRK for post-LASIK eyes. If you're more comfortable on learning PRK, then that's a good option for you. For mixed astigmatism, limbal relaxing incisions work reasonably well for less than a diopter and a quarter of astigmatism. Now, one of the things I do is use a mini PRK. I use about a 7 millimeter epithelial removal as opposed to an 8.5. Now, why do I do that? Because that 7 millimeter, you're reducing the amount of epithelial removal by 30%. That gives you a 1 day quicker epithelial healing. The patients are more comfortable, their visual recovery is quicker, and they like it more. You can also use a laser scrape with this. For limbal relaxing incisions, try to avoid going too central. You can cause coma, as Thomas Conan has shown previously, and also the wounds don't heal quite as well. There are a number of LRI nomograms available. This is Eric Donnefeld's. Skip Nickerman has an excellent nomogram, and these can be very helpful. So in summary, you want to rule out the usual suspects. Rule out and correct the refractive error. You want to see if there's PCO, mild PCO, or retinal images, retinal problems, and then correct out that refractive error. But the most important thing I can tell you probably today is you want to have that discussion about going back and doing post-IOL refinements before the procedure. If you don't, and then you have to do it, it's perceived as a treatment failure. But if you talk about the retreatments before the procedure, it's an anticipated refinement. Thank you.